So with this, we come to the final part of the seminar. Now, I'll be discussing the clinical anatomy of the facial nerve. And these are the following subheadings under which I'll be discussing the topic. So first, we'll discuss about the upper motor neuron lesion versus the lower motor neuron lesion. Then we'll specifically discuss about this in the facial nerve. Then we'll talk about a special type of palsy, which is called as Bell's palsy. Then we'll talk about some of the symptoms of the Bell's palsy. Then two very special phenomena which is called as the crocodile tear syndrome and the Ramsey Hunt syndrome. Then we'll discuss about the lower motor neuron palsy of the facial nerve at different levels. And in the end, I would like to finish by talking about chorda tympani and the lingual nerve injury. After that, for last, I have a clinical case scenario for you. Okay. So first, we'll talk about what is upper motor neuron palsy versus lower motor neuron palsy. So in this diagram, as you can see clearly, the purple one, this one is an upper motor neuron, and this one is a lower motor neuron. Okay, upper motor neuron is the motor neuron in the central nervous system, and the lower motor neuron synapses with the upper motor neuron and takes the sensation from the central nervous system to the muscle or to the gland. So let us see if this is our muscle. Okay, this is our muscle. What will happen if this is cut? This is cut. If there is a lesion in the lower motor neuron. So now what happens is that this muscle has lost all its connection from the central nervous system. Okay, there are no fibers supplying the muscle, and there's no connection between the CNS and the muscle. What will this lead to? This will lead to a special case of paralysis, which is called as flaccid paralysis. There is absolutely no contraction in the muscle. The muscle has gone flaccid. And if you guys know about the Babinski sign, the Babinski sign will be absent in these kind of lesions. On the other hand, if the upper motor neuron is injured, what is happening? The lower motor neuron has now lost its connection from the central nervous system. What will this lead to? This will lead to an overstimulation of the lower motor neuron, which will then cause rapid spasm in the muscle, which will thus lead to a paralysis called as spastic paralysis. In these kind of situations, the Babinski reflex is positive. Okay. So just to sum up, in upper motor neuron palsy, there is flaccid paralysis. In upper motor neuron palsy, there is spastic paralysis. In lower motor neuron, there is flaccid paralysis. Babinski sign is positive. Babinski sign is negative. Just like for a very basic example, just a very classical example, whenever there is tetanus, okay, in that case, your upper motor neuron is injured. What does that do? That leads to overstimulation of lower motor neuron, hence rapid spasms, hence spastic paralysis. Another very easy way to remember all this is that lower motor neuron will keep on firing. Upper motor neuron gives an inhibitory signal. This is a very easy way of remembering the differences between an upper motor neuron palsy and a lower motor neuron palsy, and it is also important, as you'll see in the upcoming cases. Okay, now let's talk about the innervation of face, the facial nerve, the corticobulbar fibers, and the nerve supply to different musculature of the face. So let us now look at the corticobulbar fibers of the facial nerve, how it is innervated, where are the fibers for the upper part of the face and the lower part of the face are coming from. Okay, so the fibers that let this be the facial nucleus. Okay, this is the facial nucleus. Facial nucleus, that is the nucleus of the facial nerve. Sorry, my bad. Nucleus of the facial nerve. This, and this. What are these? These are corticobulbar fibers coming from the higher centers. Okay. Now I've used colored pencils. Okay. So now I've used colors to make it look a little bit neat and easier for you to understand. The purple fiber, this fiber, this fiber, and this fiber. What is this lower motor neuron supplying? What is this lower motor neuron supplying? It is supplying the upper part of the face. What is the upper part of the face? Everything beyond the upper eyelid and the upper eyelid. All the musculature will be supplied by this part of the facial nerve. Now, where are the corticobulbar fibers for this are coming from? So, if you look carefully, for the upper part of the face, for the upper part of the face, the corticobulbar fibers are coming from both the ipsilateral and the contralateral cortex. So, from upper motor neuron from both sides. Let's just look at it again. This is the lower motor neuron. The upper motor neuron fiber is also coming from this side and this side. That means for the left side of the lower motor neuron, for the upper part of the face, the corticobulbar fibers will be coming from both the right side and the left side. Okay. Now let's look at the lower part of the face, the nerve for the lower part of the face. This is your nerve for the lower part of the face. Okay. If you look carefully, there is only one fiber coming, and this is your fiber. There's only one fiber which is coming down. So what we can say that the upper motor neuron for the lower half of the face is only coming from where? From the contralateral side. For the left, it's coming from right. From contralateral side. Okay. If you have understood this will be very easy for understanding the lesions. Now let's talk about the upper motor neuron lesion. For example, if there is an injury to the right side of the face, okay? If there is an injury to the right side of the face. So this is lost, and this is lost. Sorry, okay, all of this is lost. So what are all of these supplying? The pink one in this case are for the upper part of the face, so, and the green one are for the lower part of the face. Let me just draw another green one for the lower part of the face. Okay. Now just look at what all are they supplying and what all part is injured. So if you look at this one, what was it supplying? This fiber is the ipsilateral fiber. Okay, this fiber is the ipsilateral fiber which is supplying the lower motor neuron for the upper part of the face. If that is damaged, then what will happen to the upper part of the face? Look carefully. There is another fiber which is coming from the contralateral side. So this upper part of the face will be spared. Okay. Look at this pink fiber. What is this doing? This is giving to the opposite side. This is the contralateral fiber for the upper motor neuron. As we have studied earlier, there will also be a fiber for like this and a fiber like this. This is the lower motor neuron. This is the upper motor neuron ipsilateral fiber. Okay, so even that will be there. So even if this is this is damaged, it won't cause much problems because this is still there. The ipsilateral fiber is still there, which will again supply the lower motor neuron for the upper part of the face. That is why both the sides upper part of the face are spared in an upper motor neuron lesion. So what will be lost in the upper motor neuron lesion, you ask? Look at this. Yes, this is perfect. Look at this. This is okay. Sorry, my bad. Wrong color choice. Look at this. This is a fiber, contralateral fiber, the only fiber which is supplying the facial nucleus for the lower half of the face of the contralateral side. That means if this is, which means that if this is damaged, this is also damaged. Why? Because the contralateral side, this side, lower part of the face, the only upper motor neuron supply which it was having was this, and it is now lost. So what will happen in this palsy? In an upper motor neuron palsy of facial nerve, upper motor neuron palsy, there will be loss. There will be paralysis. What kind of paralysis? Spastic paralysis, right? Spastic paralysis of contralateral side, of lower half of the face. Now let's talk about lower motor neuron lesion. So this is our face. If this is the lesion, it is very clean and clear cut that this is damaged, this is damaged. So whenever there is a lower motor neuron lesion, ipsilateral, that is the same side, facial muscle flaccid paralysis. Okay, just to sum it up, upper motor neuron lesion, lower motor neuron lesion, spastic paralysis. Okay, let's just talk. Which paralysis? Spastic. Which paralysis? Flaccid. Which what part? Which side? Contralateral side. Which side? Ipsilateral side. Which part? Lower half. Which part? Both sides. Both upper and lower. Half of the faces. Okay, now look at this picture. This is a very interesting case of a lower motor neuron lesion of the facial nerve. Take some time. Try and notice the difference between the two faces, like the two sides of the face. Okay. Try to see what you can see and try to name them. Pause the video, try to name them. Okay, now let me see. If you all have tried, then that's good. If not, I'll tell you. This is Bell's palsy. What is Bell's palsy? Bell's palsy is a lower motor neuron palsy of your facial nerve. There's one specific point in Bell's palsy is that this is an idiopathic palsy. That means we don't know the cause. Okay. What all you can see here very clearly, that there are no transverse wrinkles. Okay. You see there are no transverse wrinkles. Okay. Now look carefully. Okay, the picture is not that good. If you're looking carefully at this part of the face and like so, the lower eyelid, this part and this part, you'll see that the eyes in the lower part of the face are a little everted. Okay, not the eyes, the eyelid of the lower part of the face is a little everted. That's this was point one, this was point two. The patient has come a little bit earlier, so that you won't see the epiphora, which is the trickling of tears, which is usually the case. I'm just telling you what we can see very clearly. Try to name the muscles which are involved due to which this is happening. You see, the person can smile. The mouth is going back entirely here. Okay, that means the sphincters and dilators are working on this side. This side they're not working. Another thing, if you can see clearly, is look at this. Look at the nose, the nasal opening, nostrils. Look at this. Look here. Look how is this spread and look how is this spread. Can you see the difference? Good. Now let's just for covering it up. This loss is due to the first part, the no wrinkles is due to the loss of nerve supply to the frontal belly of occipitofrontalis. Here you cannot see ptosis, but ptosis will also be present. Why? Because if you remember, the levator palpebrae superioris, which is an extra muscle to your upper eyelid, will also be paralyzed. So levator palpebrae superioris is also paralyzed. That is why there is and ptosis. There is an eversion. Why? Why is there an eversion? And epiphora. Why is that? It's just because of one single muscle, which is your right, which is your orbicularis oculi. Why is this? This is because of sphincters and dilator muscle. Okay. Another thing which you will see in the patient is that okay, there will be dripping of like there is epiphora from eye, there will be dripping of saliva from this side. Okay. Another thing, if you remember, there's a muscle here. So there's another muscle, very important muscle here, which is also paralyzed. Which muscle is it? Buccinator, due to which your deglutition of the food will be hampered. So whenever you're eating, you'll have to like use your finger to scrape out the food which is accumulated in your cheeks. Let's just look at another diagram here. Okay, so inability to close an eye. This is ptosis, facial drooping, and change in quantity of tears produced. We'll just come to that later, the quantity wala part. Other than that, if you look, there is epiphora, there is ectropion, which is eversion. There is, as you see, there is ptosis of upper lip and ectropion in the lower lip, that is for saliva. Oh, one thing that you see here is these three symptoms. Dry eye, sorry, these two symptoms, dry eye and cortical ulceration. See what is happening because your levator palpebrae superioris is not closing properly. What is happening is your fluids, your secretory fluids, which usually uh, lubricate your cornea, they're not able to spread properly throughout the cornea, which is leading to what? Dry eye, which in the long run will lead to what? Corneal ulceration. Okay. Now, this is another diagram, Bell's palsy, idiopathic unilateral facial paralysis. Okay, okay, I'll just tell you here only. Bell's palsy is also seen as complication to other diseases. The important ones are sarcoidosis, diabetes mellitus type 2, and Zostera. Okay, so now we've all heard of Zostera, herpes zoster virus. Why is this important? Because When herpes zoster virus causes the lesion of your facial nerve, this is something specific. This is a specific syndrome called as Ramsey Hunt syndrome. Okay, this is your Ramsey Hunt syndrome. It's just facial paralysis, Bell's palsy due to Zostera. Actually, this is a little bit more. When Zostera causes this, this actually causes the lesion, which will produce symptoms which are similar to lower motor neuron palsy of facial nerve at the level of first external genu. It actually produces, this virus will produce symptoms which are similar to this. We'll come to this. Okay, let's just do it right now here only. This is your entire course of facial nerve. This is a very well drawn diagram if you want to see, if you want to look at it. Okay. This is, let's take this as A, let's take this as B, let's take this point as C, let's take this point as D. What is point A? Point A is the stylomastoid foramen. What is point B? What we have taken as point B? We have taken the point B as the point just below the second external genu. Just below that means only chorda tympani nerve is coming out after that. The stapedius nerve, the nerve to stapedius is already gone, and the lower motor fibers are going. These fibers to the posterior auricular nerve and all these ones. Okay. What is point C? Point C is the level of the lateral semicircular canal. Why? Because the lateral semicircular canal has an impression here. What is this? What is this? This is your middle ear cavity. This is your medial wall of the middle ear cavity. You see, this is the medial wall, and this is coming, and this is the nerve traversing from the medial wall to the posterior wall, as you have all seen in the course of facial nerve. And let this be the point D. Point D. What is this point D? It is just outside the internal acoustic meatus, geniculate ganglion. Okay. Let's just take it step by step. At point A, okay, point A, if the nerve is injured, what all will be lost? The facial muscles which are supplied by the posterior auricular branch. Okay, what are these? Stylohyoid. So if say your nerve injury is point A, what all will be damaged? Your these four muscles and this entire branch. Let me use a better color, pink. These five branches and these four muscles. These are very important. These four muscles are supplied by the posterior auricular branch. So your these four are damaged, and your entire those five branches of facial nerve, the five motor branches that we study, temporal, zygomatic, buccal, marginal mandibular, and cervical branch. These will be damaged. What will that cause? Bell's palsy. Now let's go a little bit up, which is point B. Which nerve is going here? Chorda tympani nerve. Okay, it's the chorda tympani nerve. What does chorda tympani nerve carries? It carries the taste sensations from the anterior two-thirds of the tongue, except for the circumvallate papillae. So now what will happen? It will, and because the damage is here, just see one thing. The damage is here. Everything below this is lost, no? So that means it will also show the features of A plus loss of taste from anterior two-thirds of tongue. Okay, I have one question for you at this point. What will happen about the taste which is coming from the soft palate? Will it be lost or will it be spared? Yes, right. It will be spared. Why? Let's see. We'll see this right now. Okay. Okay, let me just show you here only. This is your which nerve? Greater petrosal nerve. It is carrying one taste sensation. What is that? Taste from soft palate. That is why the taste from soft palate will be spared. Now, let's look at point C. This is your point C at the lateral part, at the level of lateral semicircular canal. So, What is happening to point C, what is different from the injury at point B, is that there is another muscle involved here this time. What is the name of the muscle? It is called stapedius muscle. Okay, what does the stapedius muscle do? The stapedius muscle has a function of keeping the stapes in place. It's keeping the stapes stable, not letting it vibrate too much. What will happen if that is lost? See, there is a reflex in our you must have studied it in CNS physiology. There's a reflex called as dampening reflex or stapedial reflex. What that does exactly is that if, let's just say, you're hearing a very loud sound, like if there is a very loud sound in the vicinity about 180 decibels, 160 decibels, you actually are only listening about 120 decibels of that. So what is happening to that extra 40 decibels? It's lost, it's not taken up. But if your stapedius muscle is injured, what is happening? Your stapes is no more stable, it's vibrating. Even a small whisper-like sound will seem very loud and painful. What is that condition called as? It's called as hyperacusis. Okay, so there's a specific thing which is caused as nerve injury at this portion will be hyperacusis. Now, injury at this portion will be hyperacusis. Along with that, we have the same symptoms A plus B. Now let's go a little bit more up to point D, which is your injury at the level of geniculate ganglion. Everything will be same up to point C, A plus B plus point C. Plus, what will be special? As I've already told you, it carries sensory taste sensations from the soft palate. So, your taste from soft palate will be lost. If you remember clearly, the greater petrosal nerve goes out through the pterygoid canal and it relays into a ganglion. What ganglion is that? Yes, it's pterygopalatine ganglion. What happens after the pterygopalatine ganglion? This nerve, after laying into pterygopalatine ganglion, the nerve which comes out is your V2. Okay, second part of the trigeminal nerve. From there, the nerve goes, which is called a zygomatic temporal nerve. It's actually zygomatic nerve which is divided into further two branches, zygomatic facial and zygomatic temporal. So if this was like, okay, we are done with Ramsey, so I can just remove this. If this is your pterygopalatine ganglion, this is your V2 coming out. It will give this nerve, which is your zygomatic nerve, which will then again divide into two, zygomatic facial and zygomaticotemporal. Zygomaticotemporal actually again divides into two. Both of them are called as zygomaticotemporal, and this one. So this is zygomatic temporal. It will go and then relay into the nasociliary nerve, which will then supply your lacrimal glands, your nasal glands, your ciliary glands. Okay. Important thing to note here is if your greater petrosal nerve is damaged, so will their secretion also decrease, right? Okay. Now let me talk to you about a special case scenario. Okay, a special nerve. Injury to your lingual nerve. Why is this special? It's special because lingual nerve is not a branch of facial nerve, but still we are talking about it. Okay, let me just draw a very simple diagram. Okay, this is part. Let this be your tongue. This be your sublingual gland. This be your submandibular gland. If anyone can tell me which ganglion is this? This is submandibular ganglion. This is your lingual nerve. This is your lingual nerve. And this here, okay, let me just use a different color pen. This here is your chorda tympani nerve. Okay, just a reminder from where lingual nerve is coming. Lingual nerve is coming from the posterior division of the third part of trigeminal nerve. Yes, the motor root. It is not the motor root. It is a mixed root. It has both sensory fibers and motor fibers. Okay. So we know from where lingual nerve is coming. ALI. Now ALI are the is a mnemonic for the posterior divisions: orbitotemporal, lingual, and infraalveolar. This your blue one is your chorda tympani nerve. This goes here. Sorry. This goes here. Relays in the ganglion. The ganglion will now give two fibers. One directly to the submandibular gland. One it will hop on to the lingual nerve and then give to the sublingual gland. Plus, this will also carry sensations. Sensations about what? Sensations of taste from the anterior two-third of the tongue. It will go, and then release. So, let's take an example. Whenever the exam times are near, we tend to drink stimulants like coffee and tea. Okay? A lot of people prefer hot and sweet tea or coffee, anything. Let us say, for example, tea. I prefer coffee. So let's talk about tea first because it's majority people prefer tea. You like tea which is sweet and which is hot. Now, you have a few of your guests coming to your home. Okay, a few of your guests. All of them have either the injury of lingual nerve or chorda tympani nerve, or a point where both of them are common. For example, at this point, for this point, after both of them have met. Okay, lingual nerve and chorda tympani nerve have met. So you give them all tea. So this is you. This is guest number one. This is guest number two. This is guest number. This is you. This is guest number one. This is guest number two. This is guest number three. You feel the tea is hot, and you feel it as sweet. Guest number one says that the tea is hot, but it's not sweet. Guest number two says the tea is not hot, but it is sweet. Guest number three says that the tea is neither hot nor sweet. He just does not like it. What we do here right now is, it's very easy. From this information we can know what is happening here, which part is injured. So if you're feeling both hot and sweet, that means your sensations are normal. What sensations, you ask? Hot is a general sensation, where general sensations are pain, touch, temperature. Sweetness, it's a special visceral sensations. There are a lot of special sensations, but there is only one special sensation which is visceral, okay, which falls into SVA column, as you've studied in nuclear columns, okay. So that means both of them are fine. Which both? Hot, which is general sensation, is carried by lingual nerve for the anterior two-third. Taste, which is a special sense, is again carried until the point where chorda tympani nerve joins it. Chorda tympani nerve is actually carrying it, but which nerve is the one which is carrying the taste sensations until the chorda tympani nerve receives it? Right, it's lingual nerve. Lingual nerve is actually taking your sensations from the taste, both general and special. The only thing is, the lingual nerve is relaying the general sensations to your higher centers, whereas the taste sensations now from there hop on to your chorda tympani nerve, which then go forward. Okay, so now if someone says they feel that it's hot but it's not sweet, you very easily know which nerve is damaged. Chorda tympani nerve is damaged, but their lingual nerve is intact because they're still feeling the general taste sensations. third person says that he's feeling it sweet. That means his special taste sensation, special sensation, which is your sweetness, which is your quarter temporary nerve is spared, but he does not feel hot. That means his general sensation is lost. That means your lingual nerve is injured. So, if lingual nerve is injured, which nerve is actually carrying the fibers of taste? Well, that's simple. Lingual nerve is injured beyond this point. Okay, that means the taste can still go. Sorry, the taste can still come here, and then go to the to the quarter temporary nerve. But if the person is neither feeling the taste nor feeling the hot, nor feeling the hot, that means both of them are injured. Lingual is also injured, quarter temporary nerve is also injured. This usually happens whenever there is an injury in this part. Okay, I'll just draw it for you. Whenever there is an injury in this part, where the lingual nerve has delayed, where the chorda tympani nerve is relayed into the lingual nerve via the submandibular ganglion. One more thing, if you see, is that if there is an injury to your chorda tympani nerve, okay, you see chorda tympani nerve is also giving the preganglionic parasympathetic motor fibers. Which fibers? Preganglionic parasympathetic motor fibers to your submandibular ganglion, which will then further give it to submandibular gland and sublingual gland. So if your chorda tympani nerve is damaged, that also means that your secretions for both submandibular and sublingual glands are also damaged. Okay. With this, we have covered almost everything except two small points which you just need to know. Okay. Which you can actually, first one is crocodile tear syndrome. I'll just take you up to where the diagram is here. Where there is the diagram? Yeah, there it is. So if you look here carefully, this part, and you look here, Luxe. Okay, what all things I marked? This is lacrimal gland. This is sublingual and submandibular gland. If you can just pause the video and tell me what are the nuclear columns which supply submandibular gland, sublingual gland, and lacrimal gland. Pause the video and try to answer. Yeah, you're right. These are the superior salivatory nucleus, which supply all three of them. So what does the inferior salivatory nucleus supply? Well, that's simple. The only gland which is left, the parotid gland. So all the glands of your head and neck, except parotid, will be supplied by the superior salivatory nucleus, whereas the parotid will be supplied by the inferior salivatory nucleus. Okay. Now look, this is your lacrimal gland and this is your submandibular gland. What is happening is that if there is an injury, let's per se here at this level, there were fibers which were coming beforehand for your salivary glands, and there were fibers which are coming to your lacrimal glands before this. Now, as you have studied in neurophysiology, whenever there is an injury to a nerve, the nerve goes different processes, different steps to actually recover from the injury, which includes stuff like Wallerian degeneration, proximal degeneration, distal degeneration, then regeneration. Okay, so what happens at this point is, if imagine when the nerve, if the nerve is healing from here, if the nerve is regenerating from this part, there might be some mix up of the green fibers which are representing for the salivary glands and the purple fire and the pink fibers which are representing for your lacrimal glands, they can be mixed up. So now what happens is, let me just mark the mix up. Okay, my bad. So what will happen is, if this is here and this, let me just draw one here. Yes, okay, no, it's fine. Now what will happen is, whenever you have the sensations to secrete saliva, which is whenever you eat, whenever you're hungry, whenever you're thinking of food, a part of the sensation is going like this, but a part is also going from here to your lacrimal glands. What would that lead to? That will lead to release of tears, secretion of tears, even though only your submandible and sublingual glands were stimulated. So, the phenomena of accidental mixing of secretory motor fibers for lacrimal gland and the preganglionic fibers, which were then supposed to supply submandibular and sublingual gland after synapsing and relaying in your submandibular ganglion, which then leads to secretion of tears, release of tears whenever the salivary glands are stimulated, is called as crocodile tear syndrome. I think I have a picture of that. Okay, no, I don't. So, okay, it's all right. Never mind. So, just one. Now I have one last question for you. Okay. The question that I have for you is, you're working in ER. Okay. Two patients come to you. For let's say let's say my right. Okay. Both of them have facial paralysis of lower half, like from this part to this part of the right side of the face. Okay. For testing if it's an upper motor neuron lesion or lower motor neuron lesion, what you do is you tell them to move the frontal bellies of occipiter frontalis. Okay, so this wrinkling wala part. Okay, you tell them to do that. The first patient who comes to you is able to do this from both sides, from this side also, even though this part is paralyzed and this part is spared. The second patient, he is not able to do this from this half, the part which is damaged. This portion is completely paralyzed. That means he's able to move this part, frontalis muscle of this half, and your entire left side face. Okay, he's in upper part and lower part both. My question to you is, which of these patients require an immediate CT or MRI and should be taken up as a priority basis and should be treated on the priority basis? Pause the video, think about it. It's very simple. You'll answer it. Okay, so what should be the answer? You're right. It should be the first patient. Okay, for the first patient. Why the first patient? A lot of you might be thinking, he's able to move this part. Why the first patient? That's the thing. If he's able to move the frontal part of the paralyzed side, the right side, if he's able to move this, what does that mean? That means there is a paralysis of only lower half. When does that happen? Right, it happens in upper motor neuron lesion. Okay, if the person is not able to move this and not able to move this, that means there is a lower motor neuron lesion. You can't do anything about it. It will take its time. It will have to follow its course. But if there is an upper motor neuron lesion, this part is damaged. That means contralateral upper motor neuron lesion. What does that mean? That simply means that the person might be having an aneurysm, might have ruptured a vessel up here in your CNS, near your brain, your brainstem, your cerebral cortex. That means that person should be treated on an emergency priority basis, because that might spread. If there is an aneurysm, it might it will grow big and big. If there is a rupture of vessel, if there is a hemorrhage, it will spread. Tumor, well, then you have to confirm it. But okay, So upper motor neuron lesion, injury, very different causes can be there. For example, serious causes can be there. That's why should be looked before. Just to summarize, the upper motor neuron lesion, okay, the causes could be hemorrhage, the causes could be aneurysm. That is why they should be dealt on a priority basis. The lower motor neuron lesion is also important. It's not like it's not important. It is important, but not on a priority basis because it will take its time. The facial nerve is damaged after the CNS. It will take its time. It will have its regenerative processes. Okay. Just for your summary, lower motor neuron lesion going part by part. What all will be injured? Bell's palsy, facial palsy. This part won't move, this part won't move. Okay. Second thing, a little bit upper. Quadritemporal nerve is damaged. Your taste sensations are lost. Anterior 2/3 taste sensations except for the circumvallate papillae. That is lost. Third thing, what is lost? Your stapedius muscle is injured. Your stapes is not stable anymore. Hyperacusis. Even a person will whisper, you will hear it as very loud. Fourth, at the level of first external genome, greater petrosal nerve is damaged. Now what will happen? Taste from your soft palate is lost. Second thing which is lost is your secretory motor fibers to your lacrimal glands, your nasal glands, okay, which is after the greater petrosal nerve has relayed into pterygopalatine ganglion. Okay, so thank you so much, and sorry in the morning I had some network issues, and even right now I'm not able to play it live on Google Classroom. I'm recording these two parts separately and then trying to join them. Okay, and thank you so much.